I'm Elliot Tapper, co-editor-in-chief of Hepatology Communications. It's another month, and that means another great issue from our journal, and I am privileged to bring to you the best in clinical research. Again, this is a massive issue full of gold, and I'd like to share with you some of the highlights. Dr. Zobair Younossi is back at it again with CLDQ-ALD. This time, they have developed and validated a disease-specific, health-related quality of life questionnaire for those with alcohol-related liver disease. The instrument has excellent psychometric performance with high internal consistency and is now a free-to-use instrument for clinical trials and prospective evaluations of the longitudinal burden of this important condition. It is a total of 40 items across 9 domains of high importance to patients with ALD, including alcohol use disorder, abdominal symptoms, emotional well-being, fatigue, emotional well-being, itch, sleep disturbance, physical well-being, and worry. And while we're on the subject of patient-reported outcomes, I'd like to talk with you about 2 additional studies that we've published. The first is a systematic review and meta-analysis by Ambrose Chung and colleagues. This is about the symptom burden and treatment patterns in PBC. We found a few interesting things here that are worth sharing, and that is that patients with PBC in different regions of the world have very different lived experiences, where fatigue is a highly prevalent component of that experience in North America, with more than 1 in 4 persons reporting severe fatigue, but with less than 1 in 10 reporting fatigue among patients with PBC in Asia. Now, of course, many people with PBC report itching, and itching is something that we can deal with. First of all, the etiologic therapies for PBC, many of which have been reported in part in our journal, will address the itching. But beyond that, for those with persistent unmet needs, we have a variety of therapies. And are they being used? It turns out only 1 in 3 patients with PBC who report pruritus are receiving these therapies. There's a lot of progress yet to be made, despite how hot this area is with respect to drug development. And then I'll turn now to pain. Pain, in many ways, is the final frontier of symptom management. It exists in a liminal space between what hepatologists and primary care doctors claim as their own territory, where patients just suffer often in silence because they're not asked. And the medicines that are often prescribed to treat chronic pain are terrible, either ineffective or have deleterious side effects like opioids, while only partially addressing the pain for the short term. In many ways, chronic pain takes on a life of its own as the sort of bodily or nociceptive inputs bounce around in someone's head and become a total body experience. And leveraging the mind-body interaction is probably the safest and most effective way forward. Dr. Sherry Rogel from the University of Pittsburgh and the Pittsburgh VA reports a pilot intervention, a tailored pain self-management intervention for patients with cirrhosis is acceptable, and early signals are it improves pain control. So these are people who were enrolled in health coach-led 6 weekly one-on-one sessions where they were invited to attend group sessions where they would learn about the roots of their pain, the ways to control it without pills and other pharmacotherapies. And what they found is that these patients with cirrhosis, they found it totally acceptable, which is really the bar that we're holding a pilot intervention to. But along the way, what you were able to observe is that people saw a clinically meaningful reduction in the interference that pain creates for their health-related quality of life. Dr. Rogel leading the way. Future multi-center studies of similar kinds of interventions are underway as well. I'd like to shift now to India, where the great Anand Kulkarni reports on the role of midodrine in a placebo-controlled randomized trial for patients with ACLF and ascites. The so-called MIDAS trial was a double-blind randomized trial that allocated patients 1-to-1 to receive midodrine 5 to 7.5 milligrams TID or placebo for 30 days alongside excellent standard care. 130 patients with ACLF and ascites were enrolled. And what they found is that while midodrine did increase the mean arterial pressure, it didn't do much when it came to ascites control, and it did not significantly reduce renin levels for these patients. Is it because this drug is not effective? Is it because the drug was underdosed? I don't know. But there's reason to think that this is a worthwhile intervention that can be improved on. For example, that improvement in the mean arterial pressure is nothing to sneeze at, 5 millimeters of mercury. And the number of people reporting multiple paracentesis in that time frame was 6-fold higher in those who were receiving placebo. These are secondary endpoints. But it's the kind of thing I would like to see more of. And we are grateful to publish excellent randomized trials such as this, even if they miss their primary endpoint, because they advance our understanding of cirrhosis biology and get the field thinking about things we can do differently in future trials. I'd like to bring up a study that is super cool from China. Dr. Li Chen and colleagues report on choroid plexus cyst burden and their impact on lymphatic dysfunction in patients with cirrhosis. I would say a lot of these words that I just mentioned might be new to readers of the journal. But the point here is that there is a very important contribution of the neurologic lymphatic space for removing toxins, improving the metabolism of astrocytes and neurons. And this contributes to the pathogenesis of hepatic encephalopathy in ways that we are only now beginning to appreciate. And any anatomic perturbation that was developed or inborn in these patients that interferes with the flow of CSF might have an impact on the development of hepatic encephalopathy. So they performed a cross-sectional study using 3T MRI. They enrolled patients with HE, cirrhosis without hepatic encephalopathy, and healthy controls. Lo and behold, what they end up finding is that of the patients with hepatic encephalopathy, there was a significantly increased burden in these choroid plexus cysts, potentially helping to answer the question why my patient with cirrhosis has developed hepatic encephalopathy and why some do not. Of the many factors out there, one of them might be these variants in human anatomy. I'd like to shout out to our friends at the University of Calgary, in particular, Meyer Brahmania and his list of terrific colleagues. They report a terrific quality improvement study. So they reduced wait times for hepatology referrals using rigorous QI methods. So basically, the median wait time for a referral was 78 weeks. This is helping nobody. It's not helping the patients. It's not helping the primary care providers. And so when Brahmania showed up, he brought with him his expertise in QI, and through a series of 6 plan, do, study, act cycles, they were able to develop a suite of interventions that would reduce the wait list for routine referrals by nearly 50%. So what did they do? They developed a dedicated Hep B clinic. They had clear triage acuity criteria for their schedulers. They redirected benign liver neoplasms back to primary care with some guidance. Yes, they hired a couple of hepatologists, and they also created standardized waitlist management. If you are looking for a cookbook for how to improve treatment for patients with cirrhosis, so patients requiring follow-up in hepatology, you would read this paper. So by August of 2025, the median routine wait for a clinic visit fell to 8.4 weeks, and the urgent care fell from 28 to 6.6 weeks, and it remained near the 2-week target that they had wanted. The wait list for a clinic decreased from 1,400 patients to 158. Without a doubt, the kind of intervention and success story that ought to be lauded. And that's why I'm describing it for you here at length in hopes that you'll take a look. I hope that you read that paper. I hope you read the rest of our papers. I hope you enjoy this issue of Hepatology Communications as much as I did, and I will see you again at the same place next month. All the best.
Hi, I'm Carmen Wong. This month is featured with exciting basic science papers. First, I'd like to introduce a review article which summarizes the controversial roles of neutrophil extracellular traps in liver health and disease. NATs are web-like structures composed of DNA, histone, and antimicrobial proteins that are released by neutrophils. An excellent review written by Wang et al. Highlights the excessive NAT formation can lead to liver injury, impaired immune surveillance of early cancer cells, and foster a tumor-friendly environment. Neutrophil-targeted therapies also show promise as innovative treatments for liver diseases. Second, a study led by Ruben Francis and Esther Caparros showed that epigenetic drugs can restore lectin expression in liver sinusoidal endothelial cells, LSECs, to reduce hepatic Th17 immune-related fibrosis. They show that H3K9ME3, H3K27ME3, and DNA methylation regulate lectin expression in LSECs during cirrhosis. Using epigenetic enzyme inhibitors increases lectin expression. Modulating this epigenetic modification would reduce the hepatic Th17 immune response in cirrhosis. Enjoy the studies.